the people who are closest to ground, like for example, if you ask the donors for the funding landscape, governments are the units of design, right? Like governments are the ones that they're expecting to take leadership in this new environment. However, I would argue that governments sometimes themselves have a lot of blind spots about their own people, like the community clinic example that I shared, right? So the people who actually have the deepest insight about healthcare and how people at the last mile are expecting healthcare to solve their needs, they're not getting a seat at the table. When I was an entrepreneur in Bangladesh, I did not have a seat at the table to influence some of these decisions. It's only because I now sit at a family foundation that I get to talk to you and raise some of these issues, right? And I'm no different as a person than I was 2 years ago. So it's the same person with pretty much the same insights, but we're not giving people who actually deserve a voice the voice that they need.
You are listening or watching the Global Perspectives on Digital Health podcast. This is the podcast that helps you break out of your bubble. We talk about implementation, we talk about policy, we talk about regulation, everything that it takes to create impact with underserved communities with technology. We particularly focus on underserved communities and low and middle income country settings because that is such a paucity of these types of stories in these contexts. So that's what I try to bring with my experience being a clinician, having worked in both high-income and low-income country settings, and working in industry as well and policies. Today is no exception. We have the awesome Rubayat Khan. Rubayat is working currently with Endless Network. I'll let him tell you about the work that they do, but essentially investing in the actual infrastructure and the things that are needed to actually make the impact of technology reach people in underserved communities. And how do we get the most out of thinking about and implementing LLMs in the right way? How do we need to think about delivering healthcare differently? This is going to be a great episode. Let's get into the podcast. Thank you. Rubayat Khan, thank you so much for joining us. I'm going to let you introduce yourself, but I'm really, really looking forward to the learnings you've had along the way of like building and implementing, and also the journey you've now taken to take this learning to Endless and kind of scale the impact that you're having to help other people who are building as well. Please give us an intro to your story, your journey, and how you got working with Endless.
Thank you, Shubs. It's a real pleasure to be here as well. So if I have to summarize my journey, I would just say that it's a series of unfortunate accidents. I don't think I can attribute to anything other than serendipity where I am right now. And I think there's been one thing that's been consistent in my mission throughout my career, which is how to provide billions of people high quality healthcare experience whenever they need it, wherever they are. That's kind of been the consistent mission. And that has taken many different forms. So I started off, just if I go back to the start, I am from Bangladesh. I grew up in a middle class family. Taught myself to code when I was 8 years old. I was just a curious kid, never played outdoors, was in my computer, was one of the kind of first generation of kids who grew up with computers and learned to code very early, later studied social sciences and stats. So almost became a data scientist by accident. Again, serendipity. This was before that combination of skills was called data science. And right out of college, I actually had a pretty frightening experience, almost like a near-death experience, where I was stuck in a very remote part of Bangladesh while traveling and got a really bad infection. And the nearest doctor was like hundreds of miles away, right? So, and there was a moment there that I thought that I would not make it out alive, right? So just extremely difficult experience. But what that really left me with was this realization that things that I took for granted as an urbanite, I could walk to the emergency room anytime, is just not the reality for like over 100 million people in Bangladesh, right? They, at 3 a.m. in the morning when you're sick or your child is sick and potentially dying, you don't really have a place to go to. Aside from, surprisingly, the local drug shop or pharmacy that exists, right? That's the person that you call at 3 a.m. and often they show up with a injectable drug, and sometimes they save your life, sometimes they can't, but they try their best. So that's the only infrastructure that exists. So that was kind of a big eye-opening experience for me, and that has driven my work ever since. And I started my first social enterprise called Empower back in 2008. This was a year out of college with a few partners. This company, long story short, over the last 17 years, we've been able to scale up digital health infrastructure in Bangladesh, reaching about 120 million people now. I take very little credit for that, by the way. My partner, Mridul, deserves a lot more credit than I do. He has a lot more patience to work through the ups and downs. Following that, I started another venture around 2015 called Gion, which was looking at more of this informal market of drug shops and pharmacies in Bangladesh, which provide 70% of healthcare in the country and still get almost no recognition or efforts to strengthen or mainstream them. So I spent about, I would say, 8 years to try to understand that ecosystem and really figure out like what would it take to improve the quality of care people receive at this first point of contact that they have, and how do you kind of mainstream them or link them with the broader healthcare infrastructure. This was, by all accounts, an extremely difficult journey as well, because it was uncharted territory. And I think Elon Musk once said that entrepreneurship is like staring into the abyss and eating glass, which resonated deeply with me while I was going through this experience, because it was exactly like that for many, many years. But I think one thing that made me realize even more deeply was how health systems tend to kind of simplify poor people's health as some narrowly defined diseases, right? Which tend to kill people more often, but they miss the more complex tapestry of physical and mental health needs that everybody has, you and me, just as much as a person living in an urban slum or in a rural part of India or Bangladesh, right? And I think that's oversimplification of healthcare is what I am kind of fighting against right now, and trying to figure out what is that complex tapestry, what are people's needs and aspirations from the healthcare system, and how do we do a better job of providing that healthcare more holistically. So that's kind of how my mission has evolved slightly while keeping that broader frame more consistent. So long story short, with Gion, I spent about 8 years building that venture. In 2020, I found myself in a very unique position with the COVID pandemic, because the organization was one of the few that was working with this vast pharmacy infrastructure in Bangladesh, which nobody had access to, right? And doctors were not sitting in their chambers. People were showing up more at the pharmacy with their symptoms. And we found ourselves in a situation where the pharmacies felt really exposed to the virus, did not really have any protective equipment. And people were coming to them with this disease all the time. So we pivoted completely overnight and essentially focused on COVID response work for about 2 years. Until 2022, and burned through all of the remaining resources we had as a commercial venture, stopped all of our commercial operations, and eventually had to convert to a nonprofit in 2023, which is also when I I moved to the US and was, again, in an act of serendipity, if you can imagine a breakup conversation leading to a marriage. That was what it was like, because I called my investor and told him that I was thinking of moving to the States and I wouldn't be able to run the company anymore. And it was in that call that he offered me a job. So that's how I ended up in Endless, and never planned to be on the funding side, but here I am, continuing the mission in a different form.
What a journey. And it's funny because everyone, we have this conceptual thing that careers might be linear, and we kind of know that it might not be. But everyone who you speak to, almost, at least who has anything interesting to say, I think, follows such a non-linear path. And, serendipity is part of it, but you also kind of have to position yourself to be able to take those opportunities, and you have to be able to have got yourself there through the work you've done, the challenges you've overcome, all the things that you've had to do. So I mean, I have no doubt that a lot of it was your own grit and determination. So it's interesting to me, Rubayat. So Endless were one of the investors in Geon, right? I guess it was a steep learning curve from going from solving problems on the ground to thinking much more about the bigger picture and thinking at a system level. How did you approach that? How did you go from, hey, I'm focused on kind of one problem and the ecosystem of that problem, to moving to a different lens? And also, how did you fill your gap in knowledge? How did you fill your gap in finding out what you didn't know you didn't know?
Yeah. It was certainly a huge learning curve. And I think what helped was the fact that I tend to be a first principles thinker, and also that I am naturally curious. And I've always kind of thought about the systems perspective of the problems that I was trying to solve, even as I was building Geon or Empower. So that helped. But even then, I knew that I was somewhat boxed in my lenses with Empower first, where I was building a digital health company that was focused towards nonprofits and government clients, and later with Geon, where I was focused in this very specific niche of the pharmacy infrastructure. So the process that I followed was I actually had to negotiate with my employer, Endless, to spend the first 6 months just learning and not doing anything. So essentially undertook a fairly detailed landscaping exercise, starting off with desk research. I wish we had like the AI deep research at that time. It would have compressed that 6 months into maybe a month. But it was really good to read like hundreds of papers and reports of all the collective expertise of public health was saying, and try to digest all of that and triangulate with my own experience. I probably spoke to about 100 experts within those 6 months and did interviews trying to understand their perspectives on where they saw the big blind spots within global health. And I think the key challenge was narrowing down into something that was manageable for a small family foundation to make a meaningful mark in, but also something that was meaningful enough to the broader ecosystem, right? Because call me too ambitious, but I think vertically integrating to solve one particular disease is something that I've kind of fought against all my life. There is value in that, obviously. We wouldn't have made the kind of progress we've made in maternal and child health or HIV had it not been for that vertical integration. But we have kind of so far invested so much in that particular approach that we've forgotten that there is a broader, more horizontal, integrated approach to healthcare that's necessary. And all of the infrastructure that we've built are in those vertical silos. So I wanted to take that systems lens and try to see what are the cross-cutting issues that we could make some meaningful progress in. And that's how we ultimately arrived at the distillation of challenges that we're trying to solve now.
And we'll definitely get into that. But I just wanted to go back a bit. So first of all, absolute music to my ears. And we've talked about this as well. Moving from this kind of vertical, almost very artificial way of earmarking funding. You've given some good examples of where that has caused gains, but kind of if you do think about it that way, it definitely results in kind of gains at the expense of other areas. And forgetting that things are so connected, and that's where the system view kind of is so helpful. Because so when you look up the work that and the history of Endless, so for those of you who don't know, you mentioned it's a family foundation. It's part of the family foundation and legacy of Ray Dalio, and his son has taken on the baton, and historically has been involved in like gaming and edtech and that perspective. They had already invested in the work that you were doing. So what was the, I guess, pivot towards healthcare initially to kind of work with you through Geon, and then how did they land on actually we want to really go big on the global health space?
So I think the foundation generally values relationships and individual expertise a lot. That's just a way of doing things that the foundation has always prioritized. So the kind of grant giving work that we do or supporting the ecosystem, we often find the deep experts in a field and support them to do the work. And there's always been, so Matt Dalio, my principal at Endless and Ray's son, one of his core philosophies has always been that technology thoughtfully applied with a people-centered lens can really transform people's lives, health, economic opportunities, and all of these things, right? Like health, while most of the work was in edtech, there was always this broader interest in economic opportunities or health outcomes and things like that. So, but there was not really proper infrastructure to go after that work systematically. And so most of that work in healthcare was still opportunistic, like the relationship with me and the supporting of Gion as a venture. But ever since I joined, I have been given a lot of latitude in helping drive what that agenda looks like within the global health space. So as a sector expert, if I can call myself that, I've been given a lot of latitude to help shape that. And it was an experiment to begin with. It was not like the foundation was committing to a long-term focus on global health. It was an experiment initially. We tend to be quite agile as an organization. So I was brought in as almost like an entrepreneur in residence to test out what it would look like to build a portfolio, right, within the global health space. And what would that focus and strategy look like? Do we get traction in that strategy over a period of 1, 2, 3 years, and then double down based on that? So just this year, actually, after almost 2.5 years, I was finally given the go-ahead that this is now a more long-term area for the foundation to invest in. So we're moving forward. The experiment is seemingly successful, at least up to this point. So happy that we crossed that milestone and now excited about taking it to the next phase.
Super. And it's so great to have seen you do that, and congratulations for getting the go ahead to kind of go big on this, really. You've had a great lens on historically some of the challenges in space and global health. You write about it, so definitely follow Rubayat's Substack that he has. Where do you see kind of the biggest challenges right now, the biggest opportunities, particularly from your perspective as someone who's been sick as a patient in a rural area, and now as someone who's like thinking about where to really kind of create impact in a scalable way through a foundation? Where do you see the state, and how is this informing then like the big challenges you're trying to focus on at Endless?
Yeah. So let me start with the broader health systems challenges that we as a foundation have identified through our landscaping and all of this triangulation with experts. I think the broad framing, as I mentioned earlier, is that health systems tend to discount or oversimplify poor people's health and don't really take a people-centered view of designing health systems. So one example of that would be the community clinic infrastructure in Bangladesh that is now 18,000 strong. The time that those community clinics stay open, even when the 50% cases that they do, are from 10 a.m. to 2 p.m., which is when most people are either on the field or cooking their meals, right? So having worked in the pharmacy infrastructure, I know that the busiest times tend to be in the evening after 5 p.m. And that's when the community clinics tend to be closed. So we just don't have a fundamental understanding of people's natural behaviors and how do we design health systems that are responsive to those needs. Now, if you double click into that a little bit, we've identified about at the high level 4 big problems that we are trying to address. So one is the high fragmentation that exists within the healthcare space, because you have public facilities, you have private facilities, you have this informal private infrastructure like pharmacies, and there's no current integration or linkage or referral connections between these providers. So people almost have to self-integrate. They have to decide where to go for what care, right? And that's not how a convenient, intuitive health system should function. There should be seamless first point of care and referral linkages that linked to various levels based on the kind of problem that you have. So that's one. We're trying to defragment the health system. Secondly, for a long time, there's been a focus on access at the cost of quality. So just tremendous amount of focus on building new community health infrastructure, for example. But the access that people already have, which is, for example, the local drug shop, has gotten so little attention that people go there, get a deadly concoction of antibiotics and steroids, and nobody's even checking on those kinds of poor healthcare choices that people are making. So quality is extremely poor. Even with trained physicians, the quality is often very poor. In Bangladesh, the average doctor consultation lasts only 48 seconds, according to a research that was published a few years ago. You can imagine what kind of quality people are getting from those consultations, right? The third one, which I think is a long-standing challenge now, is that as health systems are evolving and new challenges are emerging, like non-communicable diseases, chronic diseases, antibiotic resistance. At a fundamental level, these are because of an incentive misalignment between what the providers are paid for and what outcomes we are seeking, right? Because the traditional healthcare system is actually a sick care system. It's something that you have a disease, you have a symptom, you go to a provider, you get a few pills, and you come back. But that's not enough to solve something like chronic disease or aging or palliative care, for example, right? So you need much more holistic, proactive, integrated approaches for these conditions. And you need to align the incentives so that providers are paid for value, not volume. So that's another key area that we are focused on. And then the last piece, which is something that I actually learned through the landscaping exercise, this was a blind spot for me as well, is this issue around self-care. Because 99% of healthcare actually happens in the home, where you're making day-to-day decisions about your diet, your sleep, your stress, your exercise. And we often completely forget all of that in favor of the 1% of time that you spend with a care provider, right? So how do you leverage this massive amount of uncategorized time even that's spent on healthcare that can lead to much better health outcomes? So these are kind of the four major areas that we are trying to address. Very ambitious, but we are making some good progress in innovations that could make meaningful progress in these areas. But I think coming back to your question about like what are the priorities now, of course, these are longstanding priorities. This will probably continue for the next 10, 15 years. I think we find ourselves at a very unique time with the shutting down of USAID and the dismantling of the global aid infrastructure. Because yes, it is a tragedy and a travesty what's happening. And it's leading to real damage and a lot of unfortunate situations on the ground where people are left without their HIV medicines and the like. But at the same time, we need to remember that every crisis is also an opportunity for fundamental reforms. Fundamental reforms actually only happen in moments of crisis, right? So if we are talking about integrated primary care since the time of Alma-Ata in 1978, and have not been able to make any meaningful progress towards it, now is probably the time when we start moving, because all of the existing infrastructure is kind of dismantled, right? So we have an opportunity to build something new in its place. And I think there are a few immediate opportunities there. So one is this prioritization of more integrated people-centered primary care that has often been ignored because we were so focused on the vertically integrated models. Secondly, I think there's an opportunity to leverage the private sector infrastructure we already have, as health systems are poorly resourced now compared to what it was even last year. We can start to look into what opportunities we have in these drug shops, in these pharmacies, and other frontline providers that we already have, and integrate them into the health system formally. There's a real opportunity to use technology to leapfrog. We will, I'm sure, talk about AI at some point in our conversation. I think this is such a transformational technology in our hands now. We could do so much more with AI than we could without, and to achieve more with less using these technologies. And finally, what I was talking about earlier about incentives, like how do we start paying for value rather than volume? Like still now, most health systems, including many in the West, are paying for volume. How can we transition to measuring value in terms of what health outcomes people get or what kind of quality care experiences people get? And how do you reward providers and health systems for delivering those kinds of value? I think those are some real big opportunities we have. Aside from decolonization as a broader movement, I think as the top-down aid infrastructure is being broken down, there's an opportunity to also decolonize a lot of the global health infrastructure that we've built. So I see a lot of opportunity in the current crisis. I'm sure that was not the intention of those who are perpetrating the dismantling, but I think there is a huge opportunity in it.
100%, and I think so. I like to press, at least from people who talk about this from a political and a policy lens on, there's really great opportunity and messaging around. Okay, this is the time to create local ownership and leadership, and I think you've described a lot of things there. That, like, what does that look like on the ground?
Mm-hmm.
How do you make that happen? How do you create the conditions so that we don't kind of, regress back into the old ways of thinking? So how do you meet the local problems where they're at? Well, I really love the example that you gave of, like, I think an example like meeting people where they're at is, instead of having the clinic from 10 to 2 when no one's going to be able to come, because that makes it a really massive decision. Like, I literally am taking away my earning potential, and therefore I'm not going to engage with healthcare, which again might be very dangerous, because that can, that could progress to a very late stage. Often we say, why, you might think in a rural situation, why do people present so late in their disease journey? Well, there's just no convenient access. So meeting people with the problems where they're at and letting people who are experts in those contexts really take the lead on focusing efforts. I also like the principles that you talked about around the 4 principles that you mentioned. Let's go through them again. So there was, one of them was fragmentation, being people-centered, and I can't remember the other one.
There was quality versus access.
Quality versus access, and I think sometimes people have this, the triangle, like quality, cost, and access. Like, pick 2, right? And can we move to a place through technology as well that's well thoughtfully applied? Kind of riffing off what Matt had said. How do we do that? How do we get the implementation right to, like, maybe it is possible to have all 3, right? Doing something at high quality with access to those who need it most in a way that is cost effective. And also, I think the recognition that you've had that those health outcomes, we need to work backwards from them and recognize that they take time, but there are lots of milestones on the way that help us know we're going in the right direction. I wanted to come into the challenges, and particularly around the technology. You kind of signposted, we'll talk about technology, let's jump in. Sometimes when I look around with, yes, this is a once in a generation opportunity with LLMs, generative AI, so much great potential, lots of big funders and investors saying, how do we leverage this technology? And I guess I worry and I observe that we have this danger of, like, going back 10 years where we were trying to stick solutions into problems, and not starting with the problem. And I've spoken to a couple of people on the podcast, like, people get conceptually, we need to think about healthcare first and what are the healthcare outcomes, and then work backwards from them. And then we know which things need a different type of innovation, changes in service design, thinking about approaches to healthcare differently. Having physical clinics that are in the evenings is a type of innovation, right? We don't need always the AI layer. And yes, of course, then there are some tasks and use cases where LLMs will just help us level up. But sometimes what I observe is that we're so excited and we're so anxious to make sure we make the most of this opportunity that we forget to think about it from this first principles lens of, like, let's start with the problem, which is what we've always been taught, in the 10 years I've been in the industry as well, in digital health. And so how do you see that? How do you bring structure so that we're not kind of investing in kind of FOMO and vibes, and we're actually using this to solve the use cases and problems that actually matter?
Yeah. No, I think you're absolutely right. And it's important to start from those first principles. The problem that I see is that people with a deep understanding of the health challenges are often not deep enough into AI to understand the opportunities. And people who are in the deep end of AI don't understand the health systems challenges, right? So I think it's important to understand both in order to marry the opportunities with the challenges. And a first principles lens definitely helps. So, for example, if you really look at let's pick LLMs as an example. AI is, of course, much broader. We can talk about the specialized machine learning models and such, but let's pick LLMs. LLMs are fundamentally two things. One is it's a conversational technology, right? So now the multimodal models are getting so good that you are able to converse with it in your natural language. I can speak to it in Bangla. Even it has like an American accent, it still speaks Bangla fairly well. So that really is a great leveler, in my opinion, in terms of the digital divide, right? For the longest time, we've worried about digital literacy and people not being able to access devices because they can't read or such. But with voice, you now have an opportunity to meet people again where they are, right? They can just speak in their natural dialect, and the AI can just pick up from there. So that's one. That's a first principles opportunity. Secondly, it's a democratization of knowledge and intelligence, right? So the latest LLMs are clinically superior to most human doctors, in my opinion. Research is showing that there are still some hallucinations, but that's also going down really fast. And I would argue that humans hallucinate just as much, if not more. So I think there is a real opportunity now, if you think about what we talked about quality versus access, right? The providers that are on the front lines, whether it's a community health worker, a nurse, a pharmacy, people have some sort of access already. Now, if you pair up that provider with cutting edge clinical intelligence like an LLM, you suddenly have the best of both worlds. You have the access provided by a local community provider that people know and trust, with the cutting edge clinical intelligence that is required to triage and treat a disease, right? And those kinds of foundational opportunities only emerge where you understand the health system's challenges and bring that lens to solving a problem. When you think about integration, for example, I think a lot about the opportunity that LLMs provide now to capture clinically relevant data from the conversations between a health worker and the patient. For the longest time, we struggled a lot with providers entering data into electronic medical records, right? That's almost starting to go away because we're already seeing AI clinical scribes in the West, and that's going to become widely available in low resource settings as well eventually. So imagine if every care provider interaction is digitized and recorded, you can finally have a continuity of care between those interactions, and people can be referred back and forth between those providers. The data can migrate with them, etc. So integration can become a real possibility with this technology. Self-care, let's pick self-care. I talked about voice. So imagine having a world-class clinical agent accessible via voice using your smartphone, or even via a feature phone like the Viamo rollout that's happening in Nigeria right now, where you can just dial a toll-free number and talk to an LLM about your health condition, right? So that's the kind of democratization of clinical intelligence we're starting to see. And we really need to think carefully about what that means and what kind of disruptions will happen as a result of that. And how do we get ahead of those disruptions and use them as opportunities? How do we ride the wave, right? So one example I'll give is I was talking to my parents who are now 73 years old and 65 years old, respectively. They were telling me how they are talking to ChatGPT almost every day or every week about their health conditions, right? And checking the doctor's opinion, reviewing reports, or asking ChatGPT to help understand their diagnostic reports and stuff like that. So if my parents who are not particularly digitally savvy are picking up the use of ChatGPT for this, imagine what younger generations will be doing and are probably already doing, right? So if health systems don't keep up with this, they'll become more and more marginalized, and people will trust these tools more than they trust their normal care providers. And to be honest, the quality of advice you can get from a community health worker or a pharmacy now almost looks laughable in comparison to what an LLM can provide you, right? So why would people trust health providers if they're not being able to keep up with the tools they have in their pocket? So that kind of disruption, which I call a singularity, is something that really needs to be thought through and health systems need to engage with those disruptions in a meaningful way and figure out how do you build systems for the future that already accounts for those disruptions and takes advantage of it.
Yeah, I think it's really interesting, and you alluded to some great points there. I really liked what you said about kind of human behavior and human thinking is kind of a black box as well. And clinicians, we talk about clinicians having a gut instinct sometimes about that. I can't put my finger on it, but there's something not right about this, and I'm gonna do X, Y, and Z, which is outside of the guidelines because my gut's telling me something. And we often talk about this kind of clinical judgment being a bit of a black box as well. I would say that one of the things that, just to add to what you said, that healthcare systems, one of the reasons they might be struggling with this is the black boxness of humans is something that we've got, at least in medicine, like 1 or 2 generations worth of experience. And so we've built risks and mitigations in the system around them. So say you set up, we've set up telephone triage in one part of the world. We've kind of got an understanding of like the pitfalls, like the where it's overly sensitive or not sensitive enough, and therefore we need the right types of safety nettings in place. We know that there's going to kind of be a variability. Therefore, we set up the system in this way to kind of catch people that might fall through the net, etc. I think one of the challenges is it's harder to understand this at technology level, and it's so ubiquitous that you can't even comprehend. People often worry about the risks around this, and where regulation is also then trying to catch up. How do you think about this? How do you think about liability of the healthcare professional who's then using this, where they might be using their, a specialist experience or clinical judgment themselves, but they've gone against what the LM has said, or a patient has followed that and actually it ended up being something else. And also health systems' own appetite to risk is different as well, depending on the need and the benefit that could occur. So this is not an easy problem to think about, and it's very contextual. How do you think about that in how you all the things that you said?
I think we often impose unfair standard on LLMs or AI in general of perfection, absolute perfection, right? Whereas the counterfactual of the human beings in real world settings with their own perverse incentives is like, if you did a real objective comparison, I would argue that at least LLMs without the perverse incentives baked into it, like, for example, you can imagine in the future, AI is having their own set of perverse incentives in terms of advertising or prescribing certain medications or things like that. But at least until now, an LLM as it stands now probably provides more objectively accurate guidance, given the same set of information as a human being would. And it's infinitely more patient, right? It provides a lot more attention to detail. Imagine if you could plug in your entire health history into that and the quality of outputs that you will get over and above what you can get with just a prompt alone, right? Because people also don't explain their conditions particularly well. One of the key skills a doctor needs to learn is how to get the right information out of a patient, right? And LLMs are not particularly good at that right now.
And just to say that, because often when we see the comparisons, right, it's in the context of perfect information. So the task is, we've got all of the information, but then you're taking that and then kind of making correlations and suggestions. And I really like that you've pointed that out. Part of along the continuum of even a consultation, that this is one task, and so. It's remembering that there's lots of tasks along that chain.
Absolutely.
Some of them you kind of need that skill and quality of care, and that the task of making sure that someone's lived experience is taken in and heard and computed either by a human or a technology, but also kind of bringing out through questioning and empathy other things that might be below the surface or not the real agenda of someone coming in, right? We can talk about accuracy of the agent or the clinician, but how good a clinician is or how good an agent is, and there's many layers to that, right? And extracting is a task as well. So I really like you touched on that. Yeah,
just going back to your question, I think different contexts have different counterfactuals, right? So if you're talking about, I live in Baltimore, I'm close to Johns Hopkins, and I could walk to the emergency room or see a MedStar or Johns Hopkins physician anytime I want, as long as I can get an appointment within a few months. But the quality of advice I'll get is probably at the best level possible for humans. But if you go to rural Bangladesh, the quality of advice you currently have is extremely poor, right? Even if you go to a formal sector physician, you're getting 48 seconds of their time. So why would you not trust an LLM with the information that you can give it to provide you better advice than that, right? That's number one. Now, I think for different types of use cases, like you said, the evaluation needs to reflect what are the use cases that we're asking the LLM to do. So if it's just basic question answering, there is a test for that, which probably most of the QA type benchmarks handle nowadays are essentially a question answering process. But then if you want to see how does an LLM equipped frontline provider, like a pharmacy or a community health worker, perform compared to a physician in that same environment, you'd need to run a different kind of test and evaluation, right? So we're actually now funding an evaluation in India where we're testing what happens when you equip a nurse with an LLM and give the same amount of information to each of them and the physician in that environment and see what is the treatment plan, triage, differential diagnosis that you can get out of the LLM versus the physician. So those kinds of evaluations need to look completely different than the QA type models. I think the standard for what you provide within a self-care environment, like right now, if you ask ChatGPT anything, it would spit out something, but there needs to be mechanisms for handoff. So for example, if somebody in rural Bangladesh is asking a question about something that could potentially be cancer, there needs to be a handoff mechanism between ChatGPT and the local care provider to say, you should go to this particular provider so that, and also alert that provider that there is potentially a patient here who might have cancer, right? Right now, we've not built those kinds of systems to hand off between health systems and AI. And the guardrails that you need for a health provider equipped with AI also needs to be completely different. So what I'm trying to say, maybe not in very articulately, is that depending on the different kinds of use cases of AI, you need to design different benchmarks, different evaluations, and you need to evaluate against the right counterfactual, right? And then you would know whether AI is ready for that particular thing, and also set up the right risk mitigation mechanisms and guardrails. For example, we now know that ChatGPT is infamous for taking people down mental health rabbit holes, right? It's really bad for those kinds of situations. It might be rare. If you're a schizophrenic, for example, like you'd be really ill-advised to use ChatGPT for your care. However, if there was mechanisms built in, the guardrails built in, that if somebody is talking about things that the AI might hallucinate or provide bad responses to, there is kind of an external oversight mechanism, right? Somebody is checking in on that conversation and making sure that to escalate at the right time. That's the right kind of guardrails that we need, which we are not thinking about enough.
Yeah. And I guess regulation and health systems and kind of clinical contexts are at variable levels of engaging with that, thinking about those guardrails. And while that's going on, people are using these, right? With great benefits and some of the challenges that you've talked about just now.
And so just one last point on that. I think, as I was mentioning, between like different environments, I think because of the regulatory environments and also the counterfactuals, I'm pretty certain that the most exciting use cases and the most exciting impact of AI we'll see, at least in the first 5 years, will be in the low resource context where the alternatives are just really poor, right? And so in the US, all of the talk is about ambient clinical scribes, which is great from the perspective of reducing documentation burden on physicians and giving them more time for patient care. But it's at best marginal in terms of health impact, right? Whereas in low resource settings like the Indian context that I'm mentioning, there are no doctors. So if you equip a nurse or a community health worker with AI, the kind of improvements you can see in health outcomes can be quite transformative. So I'm really excited.
And then I guess it comes to other existential questions around when will we see the flip where we don't only get the the health outcome benefit, but suddenly everyone's looking at solving those big upside problems because that's where the dollars are. I mean, the reason people are going for these marginal types of gain in the US and high income settings is because that's where the money is and that's what people are paying for. And so do you see that flipping, and when?
Good question. I don't understand, to be honest, the Western health markets as well as I do countries like Bangladesh. So it's hard for me to tell. I think a big barrier is obviously regulation. And you have strong doctor lobbies and hospital system lobbies that you need to overcome. So I think the incentive structures are not quite there for AI adoption at scale. And I would imagine that people are going to be far ahead of the health system in adopting AI, right? Which is probably already happening, given how free and ubiquitous AI already is. And I think we will see proxy measures of that within health systems. So maybe the number of urgent care visits might be less as a result of people managing more of their conditions at home, things like that. But it will be really hard to establish causality for those kinds of things unless we build the kind of rails between the AI and the health system. In lower resource settings, I'm much more bullish that some countries, at least, like Rwanda, for example, will really leapfrog to the next level of a health system, a truly 21st century AI native health system. And we will see tremendous gains in terms of what can be possible. And we will bring some of those learnings back in the spirit of this podcast. We'll take some of these lessons back to the US and say, here's the evidence that AI can really drive transformative health outcomes.
I love it, Rubayat. That's a nicely structured bullishness. Love it. Awesome. When we've talked in the past, and you've done a really great article on this, let's move from talking to what you've been bullish about, but to things that you're more worried about. You've talked in the past and you've written about health data poverty, ethics, health data done right. Can you give us your outlook on this, what you're worried about, and what you think needs to happen in our ecosystem to allow your worries to not be realized?
That's a really elaborate question. So I'll try my best. I think staying on the topic of AI, I think I'm really worried about what I call digital colonialism. I'm not sure if that term is more widely used, but I think you have an environment where a few companies are controlling the vast majority of our mind share in terms of the depth of conversations we're having with the AI, the amount of data they're aggregating about us. And there's currently no oversight into that. So if you look at ChatGPT, which is probably the vast majority of AI conversations now, up to 7, like there's about 1 billion conversations happening, 1 billion people engaging with the AI every week or every month. And of those conversations, about 7 to 10% are probably some related to your health or well-being in some form. If you take, like, for example, Google searches as a proxy, 7% of Google searches are about health. So you could almost automatically assume that 7 to 10% of those conversations, which is about 100 million conversations happening with AI on healthcare. Now, if you take that and the fact that these LLMs now are aggregating more granular health information about you and I and everybody else, and there's no HIPAA guidelines for that. There's no requirements for you to be able to take those records and take it to your health system. There's no interoperability mechanisms. We're leaving a huge amount of vulnerability and value on the table by letting these companies do with that data as they please, right? So we really need mechanisms to have people have more agency and ownership over their data, more transportability of their data, more integration with the health systems, and so on. So that's one. I'm worried about our ability of our health systems and regulation to keep up with the pace of technology. AI is, of course, progressing really fast. People are adopting AI really fast. And as I've mentioned with my parents, the health systems are completely oblivious to those kinds of changes, right? Like the health systems are operating exactly as they were operating 2 years ago, whereas the underlying environment has completely shifted. So unless we keep up with regulation, I think we'll see massive disruptions and loss of trust in the health system, loss of utilization, and lack of these integrated pathways for higher levels of care where necessary. I think another one is maybe some like coordination failures, or what I call tragedy of the commons here. There's a lot of AI innovators out there, but on something like setting a data standard for interoperability or transportability of patient records, nobody has the incentive to solve it, right? Because the AI companies actually don't want that to be solved because they can then keep all the data within their environment. And that is a huge problem. So how do you create the coordination incentives that allows for those kinds of tragedies of the commons to be addressed? Yeah, and then to the point about the current crisis being an opportunity, I think there's a natural tendency for us to fall back on what we know. So we might naturally gravitate back to the same kinds of verticalization of health issues, keeping some of the same biases against private providers and taboos against integrating them. So, and then of course, all of the perverse incentives like the doctor lobbies and everything that prevents health systems from being more people friendly. I think all of those things still remain. So unless there is some leadership from the governments, or I don't know where that should come from, but there needs to be some sort of a vision setting exercise of how do we want to rebuild our health systems for this new era, now that we have AI, now that the aid infrastructure has fallen apart. What is that new vision that corrects some of the mistakes from the previous years? I think I don't see a lot of coordination around that right now. So yeah, those are probably my biggest worries at this point.
And just on that last one, I think it's hard, isn't it? Because by its nature, if no context will have exactly the same approach, nor should it, right? That was the old way. We have a method, and we'll copy and paste that method to everyone. And so part of it is, like identifying the leadership and then turning well-meaning words into, well, everyone in the ecosystem has a part to play to kind of get there. So how do we get there? So I appreciate what you say, that like in this, like who kind of takes the reins and who's the kind of coordinator in all of this. That's really important to identify, right? And not an easy one, because that, again, contextual, like who takes that space? Is there anyone who can even do that? It needs to be someone who is able to have trust through various parts and layers of the ecosystem, through the actual communities who have previously disengaged. How do you bring, how do you bring trust to allow them to say, hey, you've had the rug pulled up from under you, and now we're asking you to like trust in a new way. I can imagine communities still being we're like, oh, we've heard this before, right? So yeah, turning political will into like things that matter to people,
right? And on that point, I think the people who are closest to ground, like for example, if you ask the donors for the funding landscape, governments are the units of design, right? Like governments are the ones that they're expecting to take leadership in this new environment. However, I would argue that governments sometimes themselves have a lot of blind spots about their own people, like the community clinic example that I shared, right? So the people who actually have the deepest insight about healthcare and how people at the last mile are expecting healthcare to solve their needs, they're not getting a seat at the table. When I was an entrepreneur in Bangladesh, I did not have a seat at the table to influence some of these decisions. It's only because I now sit at a family foundation that I get to talk to you and raise some of these issues, right? And I'm no different as a person than I was 2 years ago. So it's the same person with pretty much the same insights, but we're not giving people who actually deserve a voice the voice that they need. And what we need as an ecosystem.
That makes so much sense. And another assumption of mine that you challenged in this discussion is, I kind of have, I guess, through my own bias and privilege, have this assumption that, clinicians or healthcare workers always advocate for the needs of their patients. But I might have had blind spots where I thought I was actually being very paternalistic in my approach, or certain doctors groups or lobbies might be kind of gunning for the status quo in certain contexts, etc. So my own experience or my own idealism might not be reflected everywhere. So, or I might have blind spots myself. So that's a really good one to challenge through this discussion. So I thought that was a good place to talk about that when you were talking about this reality. So maybe a couple of quick fire questions.
Mhm.
You seem to have honed in really well through your career as an entrepreneur on and then your work at Endless on finding the right problems to work on. I'm thinking about this a lot. A lot of people who might be listening to this are like, hey, I want to be impacting underserved communities where I am in a high income setting, or hey, I'm trying to find a way to create impact here. And it often starts with finding the right problems. Do you have any things that you've learned along the way on like honing in exactly on the right problems to be working on so you can kind of get to the impact that you want to?
I think the key is in proximity and listening. So when we started Geon, for example, even being based in Dhaka, which is the capital city of Bangladesh, we didn't feel was enough to understand people's pain points. So we went and lived with rural communities for over a month, just trying to understand their healthcare journeys from their perspective, right? Like, why do they choose certain providers over others? Who do they trust? And what is their kind of underlying mental model for care seeking? So just understanding those things and truly listening to the patients, the providers, and accompanying them on their journeys. Just like going with a mother with their child in a and walking a couple of miles to the health facility and just waiting there for 4 hours in the sun and seeing what that's like, right? Like that's really important to empathize with the user that you're trying to solve. Still, then I wouldn't say it's enough. Like I think you might still find that there are layers like an onion. You peel like one layer. What they're saying on the surface is not what they actually mean. So one of the realizations, for example, when we started, people said that they wanted access to a health provider, like a doctor, right? So that's why we created a telemedicine service. But we understood like 3 years of doing this, that what people really wanted was not a doctor, but a quick fix to their problem, right? So they were really trying to get a pill or two that would get them back on their feet and back to work the next day. So if you gave them a strong antibiotic or a steroid or a painkiller that made them feel better immediately, that was what they were after, not actually quality advice. So a quality advice might just tell you that you need to wait this out for 7 days, but that's not good enough for that individual, right? So even what people say on the surface might not be what they're after. And so constantly interrogating and deepening your understanding of the problem before you start crafting technology solutions, I think that's really critical.
And some people, just to say quickly, some people don't even get to your first step, right? Some people think that box is ticked when you've done desk research. So always challenging your assumptions. I like that. And there's always deeper layers to the problem. So peel back those onions, people. I love it. Maybe we have time for one more. How have you got anything that you assumed or got wrong that changed how you do things or approach them?
It brings me back to what Charlie Munger from Berkshire Hathaway said about show me the incentives and I'll show you the outcomes. I think I really underappreciated the role of incentives in driving behavior when I started Geon. For example, with pharmacies, we thought that, yes, people really wanted a telemedicine service. If we gave pharmacies a connection to a trained physician or an expert in Dhaka through telemedicine, they'll just naturally use it because patients want it, they want it, and so on. But we did not appreciate that the pharmacy was actually positioning themselves as the local family physician. And so whenever they referred a patient out to a doctor, it actually devalued their own advice, right? So that was the incentive structure we were operating in. And pharmaceutical companies were pushing fourth generation antibiotics to them to sell. So however much you try to motivate them and give them right information to do the right thing, the incentives just were not conducive to providing quality service through telemedicine. So it was just a total blind spot that I kind of carry forward as one of my key lessons.
Nice one. And it very much links to, I spoke to Ruchit Nagar of Cushy Baby, and he talked about efforts in one of the states in India to kind of improve TB rates. And the incentive structure was all wrong, didn't allow for really solving the problem. So this has been so insightful. We've covered so much. We've covered your journey and your lessons. We've covered the work that Endless are trying to do in terms of solving and turning this crisis in global health into opportunity. You've given us kind of your pragmatic bullishness on the opportunities for if we implement and thoughtfully implement technology, particularly LLMs, and think about the things in the right way. We remember to go back, from systems thinking, from first principles, health outcomes first. We think about those things and think about people and meet people where they are. I really love what you said about, meeting, thinking about what the reality is on the ground for people. That example that you gave on, the clinics that were, open from 10 till 2. That's like that in a nutshell, right? So many great takeaways for people who are investing in this space, for people who are building in this space, researching this space, and moving away from old models of thinking. You've given us some really good thoughts. So thank you so much. How can people find you and get in touch with you?
Thanks, Shubs. No, this has been really a great opportunity to kind of reflect back on all of these years of working in this space, and thank you for the thoughtful questions and guidance. My Substack is probably the best way to see some of my work. It's on rubayatkhan.substack.com. If you send me a note or a message there.
And you've started a podcast. You've started a podcast as well. So have a listen to that.
It's still not fully set up like yours, but I've started that as an experiment as part of my Substack. So yes, please look out for subsequent episodes. And excited to continue to talk about some of these issues going forward.
Thank you so much, Rubayat. It's been great speaking to you. Thank you for sharing your learnings.
Thank you for having me.